So good evening, friends. It's indeed a great pleasure and privilege to join you for this teaching session, lecture ophthalmology series. And so first lecture would be on cataract. So I thank the Medusane team for this wonderful opportunity to meet you all through this online forum. As you see, cataract is a Greek word meaning waterfalls. So the patient who has been affected with cataract generally compares his vision as seeing through water, and that is the reason why this name came, cataract meaning waterfall. So nothing to do with this animal, and I take care of the cataract services at our hospital at Nirmal Eye Hospital, Tambaram. And I've been in touch with teaching ophthalmology ever since 1998 as Assistant Professor of Ophthalmology at Chengalpet and then RIO GOH Madras Medical College. So the purpose of today's session is not to teach you anything, but just to inspire you as well as guide you and take you through the entire process of learning this wonderful disease, and also taking you through the history of how this ancient treatment evolved, because the treatment for cataract started in our own country in India in 600 centuries by Shushruta, who is considered as the father of Indian medicine. So this is the picture of Shushruta operating on a patient with cataract. So as you all know, healthy eye, the lens is very clear and the light enters through the lens and then get focused on the retina, and the retina converts light rays into impulses, and this is sent through the optic nerve to the brain where it is recognized as images. So when this changes, there are a lot of vision related problems, and this update I'll be focusing on the basics of cataract, the causes, the differential diagnosis, the treatment, and before that pre-operative assessment and the complications of treatment, post-operative care, and some recent advances. I'm sure all of you would be having at least one essay notes or short notes related to cataract in your UG exam. And in practicals and viva, definitely you'll get one or two questions about cataract. So this is the major share of your undergraduate curriculum. So it's very important that you learn the various aspects of this disease. As you all know, the lens is called as crystalline lens. So basically it contains a capsule, and behind that anterior epithelium, and then the lens fibers. So this is arranged in such a way that the lens remains transparent for the whole of life. Only in the later part the lens thickness changes and people will be having difficulty in seeing the near vision. So this condition is called as presbyopia. You can see the lens modulating itself and changing its thickness because of the ciliary muscle action. And over a period of time, what happens? The lens color changes. So as you all know, the lens is made mostly of water and protein, and this protein is arranged in such a way that light passes through the protein and then focus on the retina. So sometimes the protein gets clumped together, and this clumping is called as cataract, because that not only changes the color but also blocks the light rays from reaching retina. So basically the lens contains a capsule, the subcapsular epithelium, and lens fibers, and this again, if you take the cross section, it has capsule, cortex, nucleus. So the hardening of the nucleus will produce nuclear cataract, and the opacity happens from periphery to the center, so it is called as cortical cataract. And in some patients the subcapsular clumping happens. I already told you the lens get clumped in some areas, and that is called as posterior subcapsular cataract. So what are the risk factors? Aging is one of the common risk factors, and this happens due to various reasons. One is exposure due to sunlight. That is one of the reasons in tropical climate like us, you have large incidence of cataract. And then smoking and diabetes. You all know diabetes. India is the diabetes capital of the world, and diabetes contributes to cataractogenesis in many ways. And then trauma, both blunt trauma, penetrating trauma. Steroid therapy, the rampant usage of steroids, topical as well as systemic steroids, will cause cataract. Then the other reasons like uveitis, electrical injury, radiation exposure, myotonic dystrophy, all can cause cataract. So as I said earlier, aging is the most common factor, followed by systemic disease, injury, smoking, and long-term use of certain medications like steroids. So how do we classify cataracts? So basically you can have there are multiple classifications for as far as undergraduate level, your level. So you can take this classification called etiological classification based on the etiology. So one, you can get congenital and developmental cataract, and then the commonest form of acquired cataract. So this may be senile cataract, traumatic cataract, complicated cataract, metabolic, radiation, toxic, and cataract associated with skin disease and certain other miscellaneous syndromes. There is also a clinical grading. This we called as LOCS classification. So based on where the opacity is, whether it is the opacity is in the nucleus or in the cortical area or in the posterior subcapsular area. This is called as LOCS 3 classification, and this is generally helps us in identifying the patient visual complaints in relation to the cataract. So there are two systems in that, the Wilmer system and Oxford system. So generally this is called as LOCS classification. Then you have the morphological classification, where depending on the area where the cataract starts, whether anterior capsular or posterior capsular. So here you see there are two capsules, the anterior part and posterior part. So only the capsule get cataract first, and then later on the nucleus and cortical part becomes cataractous. The second one is subcapsular cataract. So behind the capsule, so this involves the superficial part of the cortex. So this again may be anterior subcapsular or posterior subcapsular. The third one is cortical cataracts. So you I said nucleus, cortex and capsule. So this cortical part alone get involved. Then there is supranuclear cataract, where only the deeper part of the nucleus get affected. And then the nuclear cataracts, it involves only the nucleus of the crystalline cataract. So this area. And then you have the polar cataract, only the central part of the cataract of the lens will be cataractous. So this may be anterior polar cataract and posterior polar cataract, depending on where the initial disease starts, whether it's in the anterior pole or posterior pole. So these are the various types of the cataract: immature, mature, hypermature, nuclear, posterior, and then there is, depending on the staging, Morgagnian cataract. Right, these are some of the pictures. So this is called a subcapsular cataract, where the cataractogenesis or the process starts behind the capsule. And this is the nuclear cataract. You can see the brown color of the cataract, and this is because the nucleus is hardened and acquires a brownish tinge. Otherwise it is called as cataracta nigra. Nigra means black or brown. And then these are the various types of age-related cataract, and this is what you commonly come across in clinical examination. So if you see, this commonest form is immature cataract, and the examiner will ask you why it is called as immature or mature. Immature is where the lens is partially opaque. Mature cataract is when the lens is completely opaque. And hypermature cataract is where the cataract is shrunken and wrinkled, the anterior capsule becomes wrinkled due to leakage of water out of the lens. And Morgagnian is a hypermature cataract. So here the entire cortex get liquefied and the nucleus tend to sink down. So this will be the commonest question asked. What is the difference between immature and mature cataract? So in immature cataract there will be considerable vision present. So patient will be able to do their normal activities, day-to-day activities. And in mature cataract, the vision is reduced to counting fingers or hand movements. Then in immature cataract, the color of the lens is grayish white. In mature cataract, the color is pearly white. In immature cataract, since there is a clear cortical zone, you can see the iris shadow when you shine the torch from the sideways. And in mature cataract, since there is no cortical layer, the iris shadow is absent. And in immature cataract, if you see the fundus glow, you can see the red glow. In mature cataract, since the light is fully blocked, you won't see the fundal glow. So this is the difference between immature and mature cataract. So this is a clinical picture of mature cataract. You can see the entire lens is opaque and vision will be reduced to perception of light. And you see the iris shadow is not seen and the lens is pearly white. So this is just a picture to show you the stages or the difference between mature and hypermature. You can see the capsule is wrinkled and shrunken. So what happens in hypermature cataract is it becomes liquefied or Morgagnian. Morgagnian means the entire lens gets swollen, and sclerotic means the lens become compressed and hardened. And you can see the topmost part of the nucleus here, because the cortex undergoes liquefaction and it turns uniformly milky white. The nucleus loses support and then settles to the bottom. So this is the Morgagnian cataract. As depending on the age, you can also see congenital cataract. You can see cataract even in children as well as at birth, and this shows different pattern depending on where the opacity is confined. So this is the classification of congenital and developmental cataract. So basically it depends on the etiology. Hereditary is autosomal dominant. So those who are going for exams, this may be one of the MCQ questions. The mode of inheritance in congenital cataract is autosomal dominant. Then you have various maternal factor. So India is a country where malnutrition and infection is very common. So this can cause cataract in children. Then you have the fetal or infantile factor. So if you have a obstetric disease, placental hemorrhage, or a metabolic disease like galactosemia, or if there is a birth trauma or malnutrition, the child can have cataract. So basically the two etiology, intrauterine and hereditary used as autosomal dominant, and you can also see various patterns. So this is called zonular cataract, and apart from this you can get cataract following trauma. This is called a rosette shaped cataract. So this happens after concussion, a blunt trauma or a penetrating trauma or radiation or electric shock. Then you have another entity called as complicated cataract. So this develops consequent to eye disease like glaucoma or iritis or retinitis pigmentosa. You can have complicated cataract. Then you have the cataract associated with systemic disease, commonly diabetic cataract, and you can also get this in galactosemia and tetanic. Then the drug induced or toxic cataract. So this commonly steroid is a common problem. So you can also get after certain drugs like chlorpromazine or miotics. So what are the symptoms? So generally patient presents with painless blurring of vision. Many patients can have glare or light sensitivity, poor night vision or difficulty driving at the night, and some patients can experience double vision, and they might also need brighter light to read, and some may see different colors, fading or yellowing of colors. So what is the treatment? So generally we advise treatment when the cataract cause vision loss to interfere with daily activities. So this is the key word. When patient daily activities are affected by the defective vision, then you have to perform surgery. So driving, reading, taking medications, or performing the job. So how to go about this treatment? So basically any management starts with taking a proper history and also recording the vision and doing a proper refraction, and then doing a slit lamp examination basically to rule out primary cataract or secondary cataract, and eye pressure has to be recorded. This you do with tonometry, and then you have to see the retina or the macula. So what is the function of the macula, whether it is intact or whether there is any retinal disease, and you also need to check the patency of nasolacrimal duct. So there are certain investigations that required before a cataract surgery. So apart from the slit lamp examination and ophthalmoscopic examination, you also have to check the inner part of the eye. So as I said earlier, you have to check the visual acuity.
Each eye is tested individually for the ability to see letters of varying sizes.
So this is called as visual acuity test, recorded with the use of Snell and chart. Then you have to measure the axial length, the length of the eyeball. So this is necessary to calculate the power of the intraocular lens. You also need to check the corneal curvature by an instrument called keratometer. So this is necessary to select the appropriate power of the intraocular lens. You also need to check the systemic status, particularly diabetes
uncontrolled blood sugar
and
anemia
hypertension.
before the surgery.
So this is something about biometry. Basically, you have to calculate the length of the IOL power before deciding which IOL and what is the power of the IOL to be implanted. So you need keratometric reading as well as axial length reading. So this is usually got by biometry. There are various types of biometry. I will not go into the details. And there are certain myths associated with cataract. So as a caregiver, as a medical graduate, you have to know that cataract is not a film over the eye, and it is not caused by overusing the eye, and it's not an infection like spreading from one eye to another eye, and it is not a cause of irreversible blindness. Cataract is the most common cause of treatable, preventable and reversible blindness. So when you have to do cataract, and what are the goals of cataract surgery? So basically you do cataract to allow patients to minimize glasses wear and have the surgery at an age when you are still healthy and active, and this also reduces certain complications in the elderly people. As you all know, vision is very important. If the vision is impaired, the elderly patients can sustain fractures, have an increased incidence of fall, and also certain accidents like burns. So to prevent this, early cataract surgery is mandatory. The goals of cataract surgery is basically to provide the person with full range of vision and reduce dependence on glasses, particularly reading glasses, and also improve the lifestyle activities. So treatment, you can give certain glasses to improve the vision, but usually this is temporary, and the definitive treatment is surgical removal of cataract. So there are various surgical techniques. We'll see that one by one. Surgery is the definitive treatment, and if the symptoms are mild, for time being you can give glasses. Otherwise you need to do cataract surgery. So let me take you through the history of cataract surgery, how the present surgery and management evolved over a period of time, and the various surgical treatment available to the present femto-phaco. I've already told you about 3000 years of couching. Couching was the first surgery proposed for cataract surgery, and there are a lot of historical evidence that this surgery originated in India, and this is mentioned in Sushrita Samhita and the Sushrita era. But there is influence on this procedure in Greco-Roman culture and in various museums where these type of instruments are seen used for couching. So how cataract surgery evolved from cataract to extracapsular extraction, and then the capsule was causing some problem, so they removed the full lens in toto, that is called as intracapsular, and then to give good rehabilitation to place a lens, this extracapsular surgery and intraocular lens evolved over a period of time. And then the technological revolution happened. What we commonly use now, it's called phaco surgery or phaco emulsification, and the intraocular lens also evolved from rigid lens to foldable lens to multifocal bifocal lens. As you see the history of surgery, this is how surgery was done in the beginning of 19th century. You can see somebody putting the light, and there was no microscope. So at those times the medical students or the disciples used to help in the surgery. So this is how it started. You should all be thankful to the modern revolution. You need not do such acrobatics now. So ICC, intracapsular extraction, the problem was patient has to wear a thick glass. These are called as aphakic glasses, and that caused a lot of vision related problems, and there was also certain disadvantages like vitreous loss and poor vision, and you have to use a different type of contact lens or thick glasses. Then it evolved into extracapsular extraction, and then small incision cataract surgery, and then phaco emulsification. So I'll just take you through the important steps. So before IOL implantation was developed, patients have to wear aphakic spectacles and contact lenses for rehabilitation. And over a period of time, the microsurgery evolved. So we had good anesthesia, local anesthesias like retrobulbar or peribulbar. So you need not anesthetize or sedate the patient. So you can only have regional anesthesia. Then sutures came. Sutures gave a good control over the wound, so the infection rate came down. And to improve the visibility, micro instruments came into the picture, and microscope also came to see the better visualization of intraocular structures. And then we had certain drugs like viscoelastics, gases, silicone oil to help with the surgeries. The era of intraocular lenses started way back in 17th century, and I will not go into the details, but one man revolutionized thanks to the question asked by a third year medical student that you are removing the lens but not replacing the lens. So that made Ridley to think, why not we replace the lens with an artificial substance, and he went on to develop the intraocular lens. So at that time it was a polymethyl methacrylate material which was widely used in World War, and this was the first prototype intraocular lens called as Ridley's lens, made by Rayner, and this was the first intraocular implant in 1949. And over a period of time, various lenses came: rigid anterior chamber IOLs, flexible anterior chamber IOLs, then pupil supported lens where the lens was supported by the pupil, and more intraocular lens came into the picture, and then the posterior chamber lenses and multifocal lenses. So the aim of modern cataract surgery is to restore vision, achieve desired refractive outcome or the power, improve the quality of life, and ensure safety and satisfaction. So meticulous pre-operative care or planning, then intraoperative surgery, and then good post-operative management. You can see the phaco surgery being carried away in one of the videos here. This is a pure mature cataract. So for want of time, I'm just passing. So this is the capsulorhexis. and the capsule is stained with a trypan blue. This is a chemical to dye to colorize the anterior capsule for better visibility. And then the cataract or the nucleus is broken into small pieces, and these small pieces are emulsified with the phaco emulsifier, and then fully washed, and we place a intraocular lens, a foldable intraocular lens, so that you maintain this 2.2 millimeter incision. So this is presbyopic intraocular lenses. These are modern day lenses where you can correct both distance and near vision, so that patient will have good quality of life. And post-operatively, and now it is done under topical anesthesia without any need for injections. As for the undergraduate level,
during the entire surgery, the eye and the surrounding area is cleaned prior to surgery.
So this is the pre-operative preparation for the patients. So you clean the surrounding of the eye with povidone iodine and then drape the entire area. So
depending on your condition,
usually we do it under topical or retrobulbar or peribulbar anesthesia. These are the two types of surgery commonly practiced now: phaco emulsification and small incision cataract surgery.
An injection is given to numb the area behind the eyeball. Thereafter, an incision is made on the side of the eye.
So this is the animation of phaco emulsification, but I have already shown you the surgical aspect of phaco emulsification in a mature cataract. So this is for you to visualize and understand the surgery in a better way. Right, the type of anesthesia used in cataract surgery, this is called as peribulbar. Peri means surrounding the globe, and the solution we use for anesthesia is lidocaine 2% and a mixture of lidocaine with bupivacaine. Bupivacaine is slow onset, but the action lasts for 3 to 4 hours, whereas lidocaine has a fast onset and this acts for almost 1 hour. And we also use a spreading agent called hyaluronidase, and this will help the mixture to spread into the orbit properly and anesthetize the entire area. So there are two types of block: retrobulbar, so as the name indicates, the anesthesia is given behind the eye, and peribulbar, as the name indicates, it is surrounding the eyeball. So these are the various pictures. So you give behind the globe, and the area for retrobulbar, generally the middle, the medial 2/3 and lateral 1/3 junction of these areas, you insert the needle. So generally cataract surgery is now outpatient procedure, or you admit for a short time, and usually done under topical or local anesthesia. So you have to know the difference between ICCE and ECCE. Nowadays in private setup we don't perform this, but still in many areas ECCE is being performed, or it has changed into small incision cataract surgery. So this is the corneal section. You make a 180-degree corneal section and then remove the lens with a vectis, and then wash the cortical matter and then place the intraocular lens. And now this has evolved into a sutureless small incision cataract surgery, and so I'll just show you some videos of small incision cataract and various steps. So here you expose the eyeball after giving a block, and then you place a speculum so that the eye is fully exposed, and then you make a construction or scleral tunnel incision, and so this tunnel incision is self-sealing. So this helps us to reduce the number of sutures or make it sutureless. So this is how, this is a keratome or a small blade, and then you, for visibility, we put trypan blue injection, and then make a capsular rhexis, or you can also make a can opener capsulotomy. And once you make the capsular rhexis, the nucleus is separated by hydrodissection. Hydrodissection is one step where you put in fluid in between the layers of the cataract, between the nucleus and cortex. So this helps in rotation of the nucleus and separation of the cortical fibers. So once it is rotated, it is freed into the anterior chamber or into the pupillary plane, and then you can divide the nucleus and then remove, or you can remove the nucleus in toto depending on the size of the incision and the type of the cataract. So this is called as a small incision cataract surgery, and then you wash and put in a rigid intraocular lens. So this is one of the commonly performed surgeries nowadays, small incision cataract surgery with intraocular lens implantation. These are the various steps for small incision cataract surgery. So scleral tunnel construction, this is a blade we use, crescent knife. Then we make a anterior capsulotomy, either a can opener type or a curvilinear rhexis. Some people also use envelope technique, and then wash the anterior chamber and the cortex with balanced salt solution. So these are commonly asked questions. So which solution is used for washing the cataract? So usually it is balanced salt solution, and in some places people are still using ringer lactate. So this is the can opener technique because it resembles the opening of a can, and this is the curvilinear capsule, so it is smooth and round. And this step is called hydrodissection. So where you inject fluid, and in immature cataract you can see this golden ring. These are various steps of the small incision cataract surgery. I'm sure you would have seen the video and still understand the steps of cataract surgery. And then coming to the modern day cataract surgery, this is called as phaco emulsification. As the name indicates, phaco means lens, emulsification is emulsifying the lens matter into or liquefying it and then removing through a small incision. So here we use a corneal incision around 2.75 to 3.2, and nowadays it's even 1.8 millimeter. Then we use a viscoelastic substance called hydro HPMC, then rhexis, then hydrodissection, and then phacoemulsification of the nucleus, then aspiration and more viscoelastics, and then we insert a foldable intraocular lens. The wound is self-sealing, and then we give a subconjunctival injection of steroid and antibiotics, and then patch the eye for some time. So there are a lot of advantages of intraocular lens. So once it is placed inside, it's not visible. The images are clear. In aphakic glasses, the images are magnified and the image is a bit dull and distorted. Here in vision after IOL, the image is same dimension without any distortions. And ideally the lens should be placed in the back, and within the bag placement is the ideal place for placing the intraocular lens. In earlier days, people used to place in anterior chamber. This is called as AC IOL, that is before the pupil, just behind the cornea. And if the support is inadequate, you can also place the intraocular lens with this sclera. This is called as scleral fixation lenses. And we also use certain devices to fix the lens, intraocular lens, into the cataractus or area. This is called as capsular tension ring. And nowadays we perform what is called as glued IOL. If there is no support to place intraocular lens, you can also stick the intraocular lens or glue the intraocular lens so that lens can be held in position. So now we come to the third and last part of this lecture, that is called as complications of cataract surgery. So you have seen the type of cataract, the morphology of cataract, classification of cataract, symptoms, and the management part, and the various surgeries. And now what are the complications of cataract surgeries? So complications can be pre-operative. So before the surgery itself due to anesthesia, it can happen. It can happen during surgery, peroperative complications, and post-operative. So this we can divide into early post-operative and then late post-operative. And in the intraoperative, commonly for your level you should know that vitreous loss can happen due to the posterior capsule rupture, early complication and late complication, and how you manage them. So early complication, you can have corneal edema, particularly when the cataract is thick, nuclear cataract. So it can damage the endothelium while removing. So that can cause corneal edema. And sometimes wound leak can happen. Here you see the dye getting leaking from the anterior chamber. So this is called a Seidel test. So you can have wound leak. You can also have shallow anterior chamber or sometimes blood in the anterior chamber. That is called as hyphema. And one of the dreaded complications of cataract surgery is bacterial endophthalmitis. So this usually happens if the patient's own source of infection or from contaminated solution and instruments. And the late complications, I will not go into the details of the complications. I'll just cover the basic aspects. The late complications, you can have posterior capsule opacification and cystoid macular edema, again chronic endophthalmitis, and then you are placing an intraocular lens. If the support is defective, you can have intraocular lens related complications. So you have to know something called as after cataract. This happens after a few years. The lens epithelium regenerate and causes cloudiness of the posterior capsule, so thereby reducing the vision. So this you can treat with neodymium YAG laser. Some of you would have heard of femto cataract. So this is a modern day advancement of phaco cataract surgery. So instead of using emulsification, use laser energy, femto energy, to break the cataract into smaller particle, which again is removed by phaco emulsification. So this is the overview of cataract, the management aspect, the treatment, and the present surgery. So what is the future? A few lines about, because after you qualify with MBBS and after your CRRI, some of you might want to take up this profession of ophthalmic practice. So what is the future? And ophthalmology is one field where the technology is evolving at a very rapid pace. So from a first generation phaco machine to now the modern day phaco machine. So technology has saved us and helped us in reducing the incision, reducing the complication, giving better outcome and good refractive control as well as quality of life. And you can also fix cataract surgery with technology apps, so smartphone apps. So you are all younger generation are very familiar with smartphone apps. So you can even fix the surgery with smartphone apps and also schedule surgery even without coming to the hospitals. Then you can also place a chip inside the eye, cornea, or over the conjunctiva, and with this chip you can detect eye intraocular pressure, you can know the blood pressure, you can know the blood sugar level, as well as do various metabolic tests with placing this integrated circuit and chips. You all know robots coming into medicine in a big way. So robotic surgery in ophthalmology is also possible and is already come in many surgeries. Nanotechnology, particularly for treating disease which hitherto didn't have any treatment, retinal tumors, retinitis pigmentosa, all this can really be treated with nanotechnology. And for genetic illness, you can even have gene therapy, and all these retinal disease, now already gene therapy has come. Of course, the cost is huge. Maybe when you come into the practice, this therapy cost would have come down. So future of eye surgeons, how will this play out? Ophthalmology in 21st century is an interesting and exciting specialty. It's somewhere between the diagnostic dilemmas of a physician as well as the technical challenges of a microscopic surgeon, both on a backdrop of exciting new therapies and innovative technical advances. So future, the Indians are aging and they are living longer, which means they will need more medical and eye care. And this is the global market, so ophthalmic practice will be a safe and lucrative profession in the future also. And as far as job satisfaction is concerned, ophthalmology is a very satisfying job. As you see that 50% of physician surgeons are extremely satisfied and another 38% very satisfied. That means over 90% of ophthalmologists are satisfied in their career. Of course, this is American Academy statistics, and India, we are also catching behind them. So for the future ophthalmologists, if you want to see some patients, are interested in seeing the surgeries or want to examine some cases, please feel free to visit our hospital, Nirmal Eye Hospital in Tambaram. And if you want to learn something more about ophthalmology, and if you are interested in learning further, please feel free to contact us. So let's heal this world, make it better for you, for me, and for all mankind. Thank you so much for your kind attention. If there are any questions in the chat box, I'll be happy to answer. Once again, thank you for your kind attention, and thank you, Raghu, for the opportunity.
Thank you, sir. And if students have any doubt, you can just put down in the comment section so that sir will be answering it. Meanwhile, I just want to thank sir for joining with us today. It was a great opportunity for us as a student as well as for the Medusane channel to host such a great person, to such a great professor in our channel. You were very support to us even in the initial days, so I thank you, sir. And this cataract is one such important topic in as theory as well as in clinics. So only major case which we are going to have in our university is cataract. So if you have any doubt, you can just post it in the comment section, as well as in future you can just see this video in the same link which will be retained in our channel. Thank you so much, sir. I guess there is no questions in the chat box. Almost 150 plus students have watched this session today, and I thank all the viewers. And if you have any questions in future also, you can just put down in the comments box below after the session ends, so that in future also we can just clarify it from sir. Thank you so much, sir. We expect future classes from you too. And since it is a pandemic time and we have our university exams are also completely delaying without any time scheduled. So I hope that future the exams will be scheduled and we will be writing it, and these sessions will be helpful for us to write the university exams. Thank you so much, sir.
Thank you, Raghu.